They come down and join me up here. We, of course, have the Director of Anonymous Sister, Jamie Boyle. We have IBH Addiction Recovery Chief Clinical Officer, Meredith Myers. We have Thrive Peer Support Harm Reduction Specialist, Ashley Rosser. Community Assessment and Treatment Services Chief Operating Officer, John Scalish. And the gentleman who's going to help moderate the discussion, Community Assessment and Treatment Services Director of Development, Robert D. Newman. So please welcome them to the stage.
So everybody up here has already been introduced. I'd like to give everybody a chance to talk a little bit about their agencies, what they do, and if we can, we'll start with Meredith Myers from IBH.
Thank you. I work at IBH Addiction Recovery. It is located in Akron, Ohio, and we serve those that are addicted and have diagnoses of substance use disorders. We work with everything through residential treatment where people come to stay with us, all the way through day treatment, intensive outpatient, groups, individual counseling, all the way through to aftercare. So once they are progressing and doing much better, you know, they could be in recovery housing that we also have a program for. So essentially, we're just trying to treat everybody at every level of care we can. Yep.
Thank you. Ashley Rosser from Thrive Peer Recovery Services.
Thank you. My name is Ashley. I work for Thrive Peer Recovery Services, like you said. And I spend a lot of time doing harm reduction work, and what that is, it's figuring out ways to reduce the potential harms that can come with using drugs. We serve the entire state of Ohio. It's a pretty wide range we got there, and what we do is we connect people that are new in recovery to people that are in long-term recovery. It's kind of like a mentorship program, and it's statewide. We can do virtual telehealth, and what I do specifically is run the Narcan mail order program. We ship Narcan anywhere in the entire state for free to people who need it, like loved ones, people who work in the field, and really just anybody who wants to be prepared in case of an emergency. And that's kind of a long list, so I'll stop there. Thank you.
And John Scalish, the Chief Executive Officer of Community Assessment and Treatment Services.
Thank you. Again, I'm John Scalish, work for Community Assessment and Treatment Services. We have a 211-bed residential facility set in the heart of historic Slavic Village. We also have a 16-bed residential facility in Wadsworth, and we provide high-intensity residential, low-intensity residential, intensive outpatient services. We link our clients with medication-assisted therapeutic support. We also have recovery housing as well, and we're very pleased to be able to support this film today.
And last but not least, the director of the film we all just watched, which was a fantastic film, very moving, Jamie Boyle.
Hi. Thank you all again for coming out, and thank you to our amazing partners for the work you all do. It's, as I said at the beginning, just the most important thing for the community and for individuals and for people like me and my family, so I just can't thank you guys enough. And it was important for us as we roll out the film and even go to festivals to partner with these people and highlight the work that they do and make sure folks know that there are resources available. You know, arm yourself with knowledge and information, and support is the best advice I could give to anybody. And so it's great that you guys are here. And just a reminder that because we didn't do the Narcan training right after the screening, Ashley's gonna hold that out in the lobby right as everyone's leaving. We did that last night, and it was really much better, just more intimate, one-on-one, and people could ask questions and kind of take resources as they wanted to. So we're going to do that as we leave. I just want to remind people. And one other thing before I forget that would be really helpful is I put out, for the first time actually, an email list that everybody can sign up for, because nobody carries business cards anymore, and we'd really love to stay in touch. You'll only get something from the film if it would be, helpful in building our impact campaign or directing people towards resources. So we'd love to stay in touch if everybody wants to sign up for that on their way out too. Thanks.
Thank you, Jamie. So the big question we get from the film is basically, how did we get here? How did we get where we're at right now with the opiate epidemic? They discuss a lot of statistics. Some of them were a little bit older, so I want to touch on some more recent statistics. According to the CDC, from 2018 to 2020, there were 464.3 million opiate prescriptions filled in the United States. This translates basically to 47.1 prescriptions for every 100 people in the country. In the US, that's approximately 26 billion individual pills, because the average prescription is for roughly 60 pills. So nationally, the prescription rate for opiates is actually at its lowest level in 15 years. It's about 43.3 prescriptions for every 100 individuals in the US. The problem is there are some counties, and a lot of them were represented, I think, in the film, where that prescription rate is 9 times the national average. In some rural counties and Appalachian areas, the prescription rate is 390 prescriptions per 100 people. So literally everybody gets 39 prescriptions of almost 60 pills per prescription every year. In Ohio, our prescription rates have been reduced from 53.5 per 100 back in 2018 down to 47.4 per 100. So we're kind of moving in the right direction. The problem is we're still overprescribing. There were 727 overdose deaths in Cuyahoga County in 2017. Between 2018, 2019, and 2020, those numbers dropped to an average of 560 overdose deaths per year. However, in 2021, with the opiates and the COVID-19 pandemic, they jumped to 649 overdose deaths. So part of the new problem we're running into is fentanyl contamination. So fentanyl is much more powerful than heroin. As of August 2021, nearly 30% of all drugs confiscated by law enforcement contained fentanyl, and most of the time, the users were not aware of this. This is prescription pills, this is cocaine, this is drugs across the board. Right now, 80% of all overdose deaths within the state of Ohio involve fentanyl. And I would like to turn it over to Ashley, who has some more information about fentanyl, and then I'll make my ways around if anybody has any questions.
Thank you. I wanted to start by revisiting what Robert just said. So imagine in the 2000s, in the early 2000s, the market was literally flooded with opiates, right? Thank you. So if we think about how many opiate pills were just floating around out there that didn't need to be out there, then as time goes on into the 2010s, like Robert said, they started cutting back a little bit, but then introduce fentanyl on the scene, which is a synthetic opiate. It is incredibly strong, and it's normally put in patches to be absorbed through the skin or prescribed to people who have very severe pain and illnesses. But what happened was the situation that we're in, it kind of like happened by a perfect storm. So we got, we're all flooded with opiate pills, and I can actually speak to this myself. I don't know if I said I'm in recovery or not, but I have 5 years in recovery now. Oh, thank you, that's so nice. And that was kind of a part of my introduction to using drugs, was in the 2006, 2007. There was a lot of opiates out there, but they were real. So when we started noticing the cutback, we've seen more fentanyl making its way into the market. And what happens is people press these pills, people who sell drugs manufacture them with these little pill presses. So you get fentanyl in a powder, and you can basically, it's like a mold. So when you take it out of the mold, it looks exactly like what you would think it would look like. You can make it look like a real Xanax. You can make it look like a real Vicodin, and so on. So when you're looking at these two things side by side, you cannot tell the difference. And if you come see me after this, I do have a side-by-side picture description of what the real thing looks like versus what the fake thing is, and you can't tell them apart. You really can't. It's hard to see by looking. And I think, to summarize, but I think it's really important that we think about this problem coming from multiple angles and addressing all of the angles that created the situation that we're in. Bad policies, right? Illicit supply, and we need better policies going forward to change things. And I'll pass there. Thank you.
So does anybody have any questions for any of the panelists or the director? And I'm old and slow and fat, so I'll try and get up here as fast as I can.
Hi, I was just wondering, in 1999, a medical doctor had told me that anyone who has an experienced medical doctor has physical pain. There's no way they could be addicted to Oxycontin. And what I think I heard in the film was that doctors can prescribe this scheduled drug without any training.
Yeah.
So where were they getting this information that it wasn't addictive? And is that still the case? Do they still not have to have training to prescribe this?
Yeah, you only have to have a prescribing license. It can be a nurse practitioner. It can be anybody with a prescribing license. So that's physician's assistants too. It's ER nurses and doctors. They can prescribe, and I have flashes when you say that you heard that in 1999, because both my family members were still saying it to me in 2009, and it was one of the more horrifying aspects of that experience, which was that when they were so clearly addicted, I cannot tell you how many times it was repeated to me that if you're in real pain, and how we measure or define real pain is clearly subjective, you cannot get addicted. And, I was 19 and I wasn't a straight A student. I was a pretty average intelligence, and I remember just thinking, that doesn't make much sense. How could that be possible? And sometimes I think it takes that kind of innocence to see these things for what they are, because even by 1999, it came from Big Pharma, is the long story, but they were so good at infiltrating the medical system, and they paid for so many of the continuing medical education courses in this country in the 90s, and that's why, it was always a balance between how much information we provide in the film and how much we show the experience. And I'm still going, should that be in the film? Should that be in the film? So we're trying to do a lot of that through our impact work, but that's a great question. Yes, doctors are still saying that. Yes, a lot of them still think it, and not to let doctors off the hook, but a lot of them trained under a lot of these programs. And what was also so successful about the programs is word of mouth. You didn't even have to see the videos. It literally changed all prescribing practices and attitude towards opioids throughout the country for, a decade of really heavy onslaught, and then they didn't even have to really do much after that, except just, not fight back and not allow it to be fought back. So now this is a run-on, but I will just say that one of the things we're seeing a lot of is kind of astroturf-looking grassroots pain organizations. So it seems like pain patients are speaking up, and if you track back their roots, and a lot of times pharma is involved, at least in organizing them, and I have so much sympathy for these people. They're on opioids. They believe they need them to get through the day. I believe they do need them because they are now dependent on them. But they're now using people who have been prescribed opioids to fight back against any legislation to curtail it. So that's why you'll see a lot of publishing still in, major publications about, pain patients suffering, and CDC just rolled back their guidelines. So this is very much still a huge problem and infiltrating every aspect.
Any other, I see. Oh, okay, I'll be right.
Just back to the pain conversation then. So when your sister and mom went into rehab, what happened to all their pain indicators? If that was the driving force that started it? I'm just curious how, when they were completely off,
Yeah,
what
that's a great
transpired?
question. Yeah, that's one of the things I've wondered if I need to put back in the film. So yeah, they neither of them have any pain now. My sister, because she wasn't on medication-assisted treatment, went through about a year of pretty tough health repercussions. Everything from vitamin deficiency and losing her hair to digestive issues to, her system was just an overhaul, and part of that was pain. She got a lot of migraines. We were really, really worried for that whole first year, but she stuck it out, took Excedrin, took over-the-counter stuff, went to meetings all the time. And my mom, within the midst of those same symptoms, turned to medication-assisted treatment, and a lot of those were relieved. Suboxone and medication-assisted treatments, buprenorphine, also has pain-relieving aspects. So it's possible that she would be in pain if she didn't take that. But no long-term diagnoses, and I've heard this story again and again, and Andrew says often, it's very hard, but if you can get pain patients to switch over to medication-assisted treatment or off of them, their pain usually improves. Sometimes it takes a long time, like a year with my sister, to get that out of your system, and then for your natural pain receptors to kick back in. And there are still ongoing studies if all your natural pain receptors ever fully recover. But it's a good question.
My question is, how many people in recovery do you have in Akron, and how compared to what you have in Cleveland?
Can you say that again?
How many patients do you have in recovery at your center, and then how many do you have in your center in Akron?
So pain patients?
Yeah.
I can't say. That's such a complicated question because the way that it's not like a facility that anyone checks into.
Oh,
So
okay.
like with our organization, we have staff members like myself that are assigned like a general location. So like I'm a representative of Cleveland, and if someone that's wanting to be in recovery, like at a detox, for example, and they call wanting someone to talk to that's been in recovery, they would assign someone like me to like physically go travel to them, meet them in person, and be their peer supporter. It's really, the treatment is individualized based on what that person needs. So, if someone is in a detox and they do need help, we can send a peer supporter to them, is what they're called. They're certified by the state of Ohio, and we take it from there. They get transportation with us, they get counseling with us, telehealth, and it really depends on what they need. GED, license, if they need help navigating the court system or the recovery world, if they need to find meetings, it's kind of like all encompassing, and we work together with other organizations. So like if they were in a facility, we would coordinate with their representative there and so on. So it's like statewide, hard to answer kind of thing.
And I know that my mom mentions the Mayo Clinic in the film, but they're still doing really, really great work in terms of working specifically with chronic pain patients who have been put on long-term opioids who hope to come off, and they have a huge success rate. I think other places are trying to model them, but it takes a lot of resources and a lot of policy and legislative power, which they don't have so much of, again, because of the pharmaceutical lobby, but people are getting there. And I would also just say that it becomes, I think, confused very quickly. I don't know if for instance, Kayla, who's in the young woman in the film who passed away, I don't know if she would have been treated as a chronic pain patient by the medical community, even though that's what she was initially prescribed for. but addiction snowballs so quickly and takes so many different forms that you're just addressing the end form, so it's sometimes, I think, hard to know where people started.
I was just going to say, I'm not sure, what exactly you're kind of interested in, but I can tell you in Akron, at IBH, we've got, at this time, 85 people in our residential care alone, and there are 16 people on our wait list that have been cleared to come in and are waiting on beds, and then there are more people on the wait list that haven't been cleared doing like a medical assessment to make sure they're physically stable. So like when it comes to the pain management piece, I think, kind of like to reference the film, there are people that come in and have started with pain management due to different medical diagnoses that kind of were the beginning of this for them as well. But then also, as the film said, there are some people that discovered pain or more pain after the addiction. So it's hard to also differentiate, the the true pain management, and then what are the effects from their addiction.
Yeah, that's a really good point, actually, and one thing I've found that the public doesn't know as much about as I wish they did. But Dr. Andrew Kolodny's colleague, Dr. Jane Ballentine, who also started Physicians for Responsible Opioid Prescribing with him, she was one of the top pain specialists in the country at Mass General in 2001, and she was prescribing opioids for pain and for chronic long-term pain, and one of the things she started seeing was that her patients weren't getting better, they were getting worse, and she started to get really concerned because their pain seemed to be always increasing, always needing more, exactly like you see in the film, because your tolerance is going up, and she started publishing research about that, and she started trying to take her patients off, and as I said, their pain often improved once she took them off, but like with my mom and sister, what they see a lot of is you start with acute pain, a migraine, an injury, and it turns into chronic pain. And then it's this impossible battle of trying to unweave what was there from the beginning, what really developed outside of opioid use while they were taking them, what's due to opioid use, and it's literally impossible to unravel. So the only course of action, as that one blessed nurse that's in the film, is trying to help people get off and then seeing where you are. But it's not an easy task by any means. But
All right, we have a question over here. First, this is Mary Brown. She's with the Film Festival, and her and Patrick Shepard were very instrumental in putting this whole panel discussion together, and I wanted to take a brief minute to thank them both for being able to put this all together. So thank you very much.
Jamie, once again, thank you for this film. I wondered about your impact program and how you are trying to disseminate it beyond the film and the showings, and where you hope to take the film beyond the circuit of festivals.
yeah, thank you. So it's for sale right now. We're looking for distribution. We're hoping for as big of a platform as possible because we know how many people this affects. And it seems like any time we try to tailor that down, there is no doing that. But in conjunction with that, which we hope will be in the fall, late fall of this year, we're going to launch a full-scale impact campaign that basically, so part of the reason I asked about the email list is that we're designing that as we go. So we're holding brain trusts in different cities, and with folks like these guys, we will invite them back for a brain trust with people in other cities, and then we can decide where the need is most and what it is. We're also talking to medical schools about doing a new continuing medical education program for doctors. And then, as Ashley said, the need is so great that it's a constant battle between where we put our resources. Is it Narcan for everybody? Is it Narcan training? Is it overdose prevention sites and fentanyl test strips? Because that's the face of it now. Is it lowering prescribing rates and going after, not going after, but advocating the CDC to reinstate stricter guidelines? One of the things that we've had feedback from doctors, they feel like this film would really has a great potential to help people who are in chronic pain and taking opioids and maybe see a way or a path forward, and their doctors. So we are going to try to use all of that feedback in designing the campaign, and we're looking to communities and audiences to, one of the things we're doing is like an audience survey, and it measures basically what you learned from the film, and that will help us to kind of tailor that program, because we certainly want to use it as much as possible for making some headway on this. Thank you.
Thank you, Jamie. I enjoyed it so much last night, I came back again today. So a question was, any long-term side effects that your mom has experienced from being on MAT?
Yeah, no, she's been on it for 13 years now. Do I have that right? Yeah, can't believe that. But no side effects so far. We're always on the lookout, and I answered last night and said, she is on other psychiatric medications, an antidepressant/anti-anxiety, and there are common side effects between the two. There's drowsiness and insomnia, so she experiences a little bit of that, but recently was told she has sleep apnea, so it could not be because of that either. But no, nothing drastic. The hardest part for her has been accessing it, and just one important thing I said last night is that, I was told it was important, thanks to Ashley, but, I wish it is unnerving having them on such a relatively new drug, as, people felt that with the vaccine, but it's right now, it's clearly the best we have that's the safest for the widest range of people, and yeah, no, nothing bad to report.
And how much longer are we going to have the Purdue Pain Scale?
That's a great question. I don't know. I had a friend who had surgery yesterday and said, the first question, what's your pain level? Right out of surgery. So yeah, I don't know. That's actually one of the initiatives we're hoping to work on with the impact, is at least, because when doctors find out that's where it originated, they are irate. So that's one of the things that we're kind of going to try to chip away at, if it's even in a continuing medical education course or whatnot, because it creates a real mess. And one of the problems, actually, a doctor just told us in Montana that you can lose your license if you don't adequately, I should say, treat a patient's pain. That is one of the things that is one of the ways patients can rate their doctors. And so the pain scale contributes to that. If you're not treating their pain, doctors will lose their license. So it's sometimes looking at those things and figuring out how doctors are between a rock and a hard place, and then trying to get rid of one of those things. So that's another thing we're trying to get rid of, is that standard that would make them lose their license. At least we could maybe make them go into review or further investigation, but like outright losing your license, that's just a surefire way that they're going to keep prescribing them in order to keep their job.
Just to touch base on that, so a friend of mine is an anesthesiologist in Texas, and one of the requirements with the pain scale, he's required to give the pain scale, but they are required to do that because the patients will come out, they'll rate the hospital. They're asked to rate the hospital. They're asked to rate their care, the doctor, and everything else. And it is all correlated to not just the possibility of losing their license, but if somebody is in a lot of pain and they feel the doctor's not doing enough, then they get a poor rating, and then it reflects poorly on them, then the hospital gets involved with the doctor. I mean, it's very ingrained policy right now, so I do think it's going to take a lot to change that, even though it should be changed. Yes, next question here.
I guess I wanted to say something about the whole pain scale and surgeries. I just had surgery on March 17th. They asked me when I was in the second recovery area, or the first recovery area, and I don't remember, to be honest with you, what I said, but it was a fairly low pain level. And later I found out, and I was annoyed, I have to tell you, that they hadn't given me any of the strong anything, but because now it was really starting to hurt. And when I said, well, I thought you guys were giving me something in my IV, and they said, no, because your pain that you reported wasn't that bad. So in hindsight, they were actually doing what they're supposed to be doing. So at that point, I did have her give me something, and I have a prescription, a couple prescriptions. I have several surgeries for Oxy sitting at home, and 12 pills is all they were giving me with no refills. And a couple of the surgeries, I didn't touch them. This last surgery I did, but I only used my little 12 until I could be fine. But yeah, this has been I learned a lot today, so yeah. And I can't help but ask, and I know it's personal and don't ask, but I'm sure everybody wants to know. You were in the middle, you and your dad. I watched this, and all I kept thinking about is how hard to be in the middle of that and see both your mother, because even before your mom finally in the film started talking about it, you can't help but think, oh my gosh, she's got a problem and she's trying to help her daughter, but is she realizing she does too? And that was also, but the fact that you're saying since 2019 your sister has stepped away, that's sad and scary, because I keep wondering, the whole, will she be okay by herself? And I didn't know if you had anything you could share or wanted to, and if you don't, that's perfectly fine. I have a lot of estrangement in my family. That's part of the reason why I'm asking too, is not drug related, but just in general. So sorry for the long question.
No, that was really great and helpful. Thank you. Yeah, no, most people ask right off the bat, so that's fine. It clearly opens the door for questions, and I realize that. One of the reasons I did include it is that of all the family estrangement that did happen during COVID, that happens in general in families, but also during COVID, also when you're up against crises of this magnitude, the scale that just seems so impossible, it often tears those bonds. And so, there has been other stuff that could or could not be attributed to their substance use disorder in the interim years between when they got clean. And so I could have gone into all that. That could be why she pulled away. It could be COVID. It could be recovery. It could be she had another baby. We don't really know for sure, and I'm really, I'm totally respecting her privacy, and I think sometimes, I think sometimes I kind of wanted to leave it ambiguous, because I don't know why, but it's where we are right now, and I felt like the more I told people, the more, similar with our story with opioids, the more people were like, oh, that's me too, or, I've had something similar, and so it felt important to put in there. Also, she's not here, and at the premiere, my parents were there, and she wasn't, and it's very clear that she's pulled pretty strongly away. So yeah, as any family with estrangement, I hope we heal and move forward, and I'm still the little sister, like constantly pestering her, want to talk, and telling her I love her. But yeah, we worry about her recovery with that all the time, and that's another reason I wanted to put it in there. I worry about it every day, and it's this impossible situation. You don't know when to push and when to pull back, because pushing them could be harmful too. Pulling back could also be harmful. And I think my family members, all of them did a great job of saying, like, yeah, families are left in impossible situations, and it shouldn't be left to the family, because there are no right answers, and you don't know, and it's different every day. And to your surgery question, not question, but statement, that was just a really good comment about how the pain scale is so messy, because it can also lead to not getting relief. And I've had friends who are afraid to take opioids for those 3 to 5 to 7 days after surgery, and I want to be clear that that's okay. We're talking about around the clock, usually longer than 7 days. Everybody's different. Usage, and usually for long term, but it's important to be careful, to know yourself, and to only take them as needed. But that's a big personal responsibility, and if you happen to be going through anything else in life, I think you're all the more vulnerable to potentially falling down that rabbit hole. So it's just a precarious situation, and I wish doctors were more armed when they hand over that prescription, that ideally nobody would have any left over, because you wouldn't be, given that extra amount. But it's a tough situation we've gotten ourselves into.
That makes me feel happy that they only give you 12 with no, refill, because they were being responsible.
Yeah, no, that's a big improvement.
I remember looking at that going, that's only going to be 3 days. What do they think? But this is a good thing.
And that was all you needed in the end? That's great. I like to hear that. Yeah, no, that's great.
So we have time for one, maybe two quick questions left before Patrick kicks us out of the theater.
Hi. You spoke about putting this information and changing things through continuing education. With that in mind, has there been any talks regarding health education and maybe start at a younger base? Because usually in all high schools across the U.S., health education goes through, all types of drug abuse, including cigarette smoking. And so this might be another thing to add to the drug use. And, the more knowledge is power. And that might give somebody moving on to when they go to a doctor's office, they have that information and they can, if a doctor does prescribe something, they can ask questions. A lot of people, they just, if they don't have the knowledge and they don't ask the doctor those questions. Why are you giving me this? Are there side effects? Is it addictive? And if we start at health education, this may help also.
Yeah, I had a high school teacher in Colorado ask if we would consider bringing it to high school. So, yeah, I mean, we might have to cut out some of the cussing, or maybe high school kids, I don't care, I don't know. But yeah, so that's something we are exploring, because it seems we've had some of the film teams show their kids who are high school age, and they seem to really, it seems to be relevant with them. And maybe I'll pass to one of these guys to talk about any youth work, because I know too, just the fentanyl making its way into recreational drugs like Xanax and stuff. I had a dental hygienist last week that told me her son, who was in high school, relapsed and thought he was just taking a Xanax, but it was laced with fentanyl, and he died on the spot. So, yeah, sorry, I'll just kick it to you for any youth programs, and we'll certainly bring the film there as part of Impact.
So this is definitely a very layered conversation once again. There was a lot going on in that question that I wanted to talk about, but specifically with youth, the Just Say No campaign that started, with the drug war era misinformation and scare tactics really doesn't work with children. It doesn't work with teenagers. We really need to change the way that we're having this conversation with them, because they're young adults, they have a mind of their own, and they're gonna start experimenting regardless. And that's exactly what I got. That's what I got. I lived through it. My family was really conservative. They didn't want to talk about anything, but they were all shielding their own addictions in some way. Heavy smokers, drinkers, whatever, drugs they were using. But when it came to myself and my siblings, we were not allowed to have that conversation. It was just, nope, doors closed, that's it, we don't do it. Look what happened to your other family member, who doesn't have the best life right now. But I think that kind of speaks to youth as a whole. We need to start changing the way that we talk about drugs with children, and how to reduce consequences that come from drug use, and this is one of them. Even if it's accidental, I think that if we phrase it the right way, we can use it as a preventative measure to even have the conversation in the first place and not make it something scary. Because what's happening is children are doing it anyway, behind closed doors and in secret. And this is what's happening. People are getting together, partying, high school parties, it's just a normal thing. And they're gonna wanna experiment eventually, and they're just gonna get a bad batch, I mean, it's been happening for a few years now since fentanyl made its way into the market. But this is a good example of why we should be working our way to change the conversation.
All right, well, our time in the theater is up. I would like to thank everybody for coming out to see the movie. I would like to thank our panelists, Meredith, Jamie, Ashley, John. Thank you to Patrick and Mary again for setting this all up. And thank you guys, everybody. Have a great evening.
And Ashley will be out in the lobby to do a Narcan training and handout, and there's resources and papers. And yeah, thank you all so much again. And thank you, Robert.
Thank you.
All right, everybody, we did let this go long because the conversation was so important, but we do have another screening in 25 minutes, so we need to turn this auditorium around. But the great news is there's plenty of room in the lobby, so if everybody could just go directly to the lobby, then you can continue the conversation out there while we prepare for the next screening. Thanks again for joining us this afternoon.